For the latter half of this presentation, we'll review some of the strategies for successfully implementing an AUC-guided approach to vancomycin dosing. And I did want to note that based on the initial poll question, it appears most folks are just getting started in this journey. So hopefully this will be a helpful toolkit in your journey. Before we dive into AUC-based dosing implementation strategies, let's set the stage with a quick patient case. Here we have a 32-year-old, otherwise healthy male who presents to the ED with a 3-day history of what appears to be a lower extremity soft tissue infection. In the ED, he has sepsis physiology, so they draw some blood cultures, start him on vancomycin ceftriaxone, and admit him to medicine. Shortly after admission, you get a rapid diagnostic page from your microlab about his blood cultures resulting with MRSA. Your hospital protocol for serious MRSA infections prescribes a trough goal of 15 to 20, and clinically he's improved, but an appropriately drawn vancomycin trough results at 13.6. At this point, what should be done? And at this point, I'd invite everybody to answer the poll question on the screen. Do we want to continue the 1 gram Q8 regimen that he's on? Do you want to increase the dose to 1250? Do we want more information? And as a stewardship pharmacist, I'll tell you answer D is not correct. We don't switch to Dapto. It looks like we have some people that are saying, about half of us saying we want more information. And then the remainder of the responses are to either increase the dose or continue the 1 gram Q8 hour regimen. I'm sure there can be several arguments to be made here based on varying hospital protocols and dosing strategies, but from my perspective, I would want to know more information before making a final decision. The trough may not be at our prescribed goal, but we also saw Tom present some data on the poor correlation between troughs and AUCs, and the patient is clinically improved, so let's see where we stand. In this instance, we see that on the current regimen, the patient's AUC was already therapeutic at about 582. Had we pushed the dose to get a trough of 15 to 20, in this case 17, the corresponding AUC would have exceeded 700. And again, based on some data that we saw Tom present, we see that toxicity starts to increase when we push our troughs past 15 or our AUCs above 700 to 800. A dose increase here would be unlikely to increase effectiveness of the drug, but would put the patient at an increased risk for toxicity, and that's potentially by several fold. I don't want to spend too much time on this slide here, but I do think that this is an important communication tool when implementing an AUC-based dosing strategy. This tool was originally developed for business and sales, but it's effective here as well. When you're trying to sell someone a product, you have to provide a succinct reason for why someone should replace their current product with yours. Here, we have to break a highly ingrained reflex that serious MRSA infection equals a vancomycin trough of 15 to 20. If you don't provide the right insight path for why trough-based dosing approaches are flawed, implementing a new AUC-based dosing strategy is going to be difficult. So if we fill in our AUC-based dosing pyramid, we start here at the bottom. We saw that troughs were a poor surrogate for the AUC, so the insight to be had here is that troughs are therefore a suboptimal dosing target. Now that we can easily and reliably calculate AUCs in clinical practice, particularly with Bayesian dosing strategies, this should be the dosing metric that we strive for, because the current trough-based dosing strategies are outdated. Now, this is just one example and one piece of the puzzle, but remember, this is probably one of the biggest paradigm shifts in drug dosing and monitoring to come about in the last decade or so. Accordingly, we want to make sure that our communication strategies are effective in expressing the need and rationale for making this switch. The next several slides are arranged as a stepwise series of questions we asked ourselves as we navigated the waters of switching from trough-based to Bayesian-based vancomycin dosing at Cedars. Accompanying some of the questions, I've included key resources or pieces of data to support all of you in answering these questions at your respective institutions. Not all of these questions may apply, or there may be additional questions to ask, but I believe these questions should provide a solid starting foundation. Step one is, of course, to identify the scope of the problem. Are you currently using trough-based or AUC-based processes? Some may be going right from trough to AUC strategies, whereas others may be moving from first-order AUC calculations using Excel or some other tool over to Bayesian. Also, who is currently performing the dosing? This is who you're going to be targeting for more in-depth education. I think the biggest single barrier I would anticipate folks will encounter, again, based on our experience at Cedars-Sinai, is breaking that 15 to 20 trough habit. A lot of the assumptions and strategies that we use with first order trough-based monitoring may not apply to Bayesian dosed vancomycin dosing. So how you do this will vary, but ultimately will depend on the resources available to you and your clinician's underlying knowledge, experience, and leadership. Once we've defined the scope of our problem, we then move to determining how we're going to calculate the AUC. Do we want to use first order, two-level PK, like Tom talked about, equation-based dosing using an Excel calculator, or do we want to use a Bayesian-based platform? If we go the equation-based route using Excel, who has the expertise to program and manage this? If we want to follow the new guidelines to the letter, our preference would then be to use Bayesian-based methods. In addition to some of the advantages of Bayesian-based methods that Tom had highlighted previously, you also have the advantage of more advanced modeling, potential to have EHR integration for improved workflows, and you really get some more flexibility around your level timing. You have to consider which program will be most cost-effective based on what models you're interested in. Some Bayesian-based platforms will offer different models or how many users you may have. For example, if you're rolling this software out to all of your clinicians, or are you just rolling this out to select group? For example, if your institution has a per pharmacy dosing protocol, maybe you need a smaller group of users, such as just your pharmacists. And really, this was one of the key tables that we presented to our leadership in making a decision to Bayesian or not to Bayesian, if you will. So if we further compare the methods of first order pharmacokinetic AUC calculations, we see some additional advantages to Bayesian-based methods. Whereas our first order methods are fairly static, we have to extrapolate over various dosing intervals, or if we're changing dosing intervals, that becomes problematic. Bayesian methods are adaptive and predictive. Rather than requiring two levels to be drawn preferably at steady state, like with the first order equations, Bayesian-based methods can be drawn prior to steady state within the first 24 to 48 hours. There are some considerations around using one or two levels, which we'll discuss shortly. And with Bayesian methods, what matters most is the accurate recording of the level draw times and the dose administration times. As long as those deltas between those two variables can be accurately calculated, that level is considered valid from a Bayesian dosing standpoint. So if a peak is drawn late or a trough is drawn early, that's okay. Our Bayesian methods can adapt, whereas our first order equations require those precisely timed peaks and troughs. This with Bayesian dosing really allows you to have some more flexibility in your level of timing and schedule with other labs, such as morning labs, rather than requiring a separate stick. Now that we've made a decision to proceed with Bayesian-based dosing methods, how do we justify the cost of the software? The major justification for the cost of this Bayesian platform is going to come from the cost avoidance associated with excess vancomycin toxicity when dosed for a trough of 15 to 20. Emily Heil and colleagues from Detroit Medical Center published their experience in switching from trough-based to AUC-based dosing. Post-implementation, they observed a 50% relative reduction in the rate of nephrotoxicity in patients receiving vancomycin. This is very much a back-of-the-napkin calculation, but if we correlate this reduction in toxicity with the excess cost of in-hospital acute kidney injury, we see substantial cost avoidance. In this hypothetical medical center, which provides 1,500 courses of vancomycin per year, we see approximately 45 cases of nephrotoxicity avoided, resulting in excess of $600,000 in cost avoidance after factoring in the cost of Bayesian software. Even if this calculation were a twofold overestimate, substantial cost avoidance still exists. So now that we've decided on a Bayesian dosing platform, we have a solid framework for justifying the costs. What do we need to think about next? Well, do we have a clinical pharmacy expert who can coordinate these efforts? And is there a physician champion we can partner with? Do we need any committee approvals? Probably at a minimum, your antimicrobial stewardship or pharmacy and therapeutics committees. But are there any IT-related committees which need to think about here? I know our IT folks were, one of their major requests for us was using a single sign-on process where our hospital credentials could be used to log in to our Bayesian dosing platform. So that was something that we had to review with EIS. Any contracts will also likely require review from our legal teams. And once we have an idea of who needs to approve these metrics or these recommendations, we need to think about how we want to package that information. The cost avoidance data presented earlier will likely be a strong selling point, but in structuring these communications, think back to our insight pyramid. Once the initial planning phases have successfully been completed and we have our key stakeholder buy-in, we need to think about revising our dosing policies. Do we need to have any exclusion for AUC-based dosing? I have some key groups that we might want to exclude listed on the slide, though this may vary depending on the AUC methods that are being employed. In your dosing protocols, providing some guidance on organisms and MICs will be helpful, as Tom discussed. I think this will likely be a frequently asked question based on our experience. Remember, when we're referring to AUC, we're really talking about that AUC to MIC ratio, but seeing most Staph aureus isolates have an MIC of 1 or less, that denominator doesn't really come into play for the most part. If the MIC ends up being less than 1, as Tom discussed, don't adjust your AUC goal. There's just not any evidence for doing that yet. However, if it's above 1, you may want to provide some guidance on considering alternative therapy, particularly in that patient that's failing to respond to vancomycin. But the big question is, what about non-Staph aureus isolates? Most of our evidence for AUC to MIC dosing for vanco comes from Staph aureus bacteremia. That said, there are some preliminary data suggesting these AUC targets for efficacy are similar in enterococci. Plus, Staph aureus is one of the most virulent organisms we encounter. So if our AUC goal of 400 to 600 is appropriate for these severe Staph aureus bacteremias, it would likely be appropriate for other less virulent gram-positive organisms as well. But again, there's limited data. So this is just something that you have to make a decision at your institution, risk versus benefit. But remember, troughs of 15 to 20 have always been a surrogate for exceeding that AUC minimum of 400 anyway. So take that with a grain of salt. Additional dosing policy updates will likely include guidance on choosing the right model with within your Bayesian platform, particularly if you purchase multiple. For example, maybe you purchase a standard model, a complex or critically ill model, and an obese model. What patient populations do you apply these to? You want to have some standard processes in place so that the dosing is consistent across clinicians. As you heard Tom discuss, the updated guidelines recommend 2-level PK using Bayesian methods, but can you broadly implement this for all patients at your institution? I think for many, including where I've practiced, 2 levels for all patients certainly can be challenging. So what if patients go home on vancomycin? How do we continue their therapy? It's another question we asked. Hopefully, for some of those that are on this webinar, there's going to be access to Bayesian dosing on the outpatient side. But if not, I've generally recommended that if the patient has a therapeutic AUC at a given trough value, that same trough value be targeted on the outpatient side, though it does get tricky if patients' renal functions or dosing intervals change. So just having some guidance there is helpful, and is something, a point of education for your clinicians that are dosing. So we raised the question on the previous slide and earlier in the presentation, is there any data for supporting single-level sampling with Bayesian dosing methods? Turner and colleagues asked the same question and compared Bayesian methods to a reference AUC using richly sampled PK data. Overall, they found that the trough-only sampling was quite accurate compared to the reference AUCs. So in practice, if we're aiming for the middle of our AUC range, so approximately around 500, then the slight variation here within that single level sampling would probably have minimal effect on appropriate target attainment. And a single Bayesian or single level Bayesian AUC calculation is more accurate representation of overall vancomycin exposure compared to a single trough value in the 15 to 20 range. That said, the two-level sampling did improve the accuracy of the Bayesian calculations in this study. So as Tom mentioned, we would still want to perform two-level sampling in patients with either severe infections or critical illness, or those with potentially dynamic renal function or other factors that may further alter vancomycin PK. So we're getting into the home stretch. It's time to pick a practical go-live date and assign various roles and responsibilities for the implementation process here. Develop some training procedures, and I would recommend using a case-based competency assessment to ensure that those using the software can demonstrate the skills necessary to use the software effectively prior to dosing an actual patient. If we have a per pharmacy dosing protocol at our institutions, we'll also want to be sure and arrange some abbreviated provider-oriented education on the change in our dosing procedures for vancomycin for those that are most likely to order the drug. And I would also encourage using some real-time education in the form of a comment that accompanies vancomycin results in your EHR, just as a reminder that levels may be different than expected, i.e. not in that 15 to 20 range, because it's either a peak or a random level or some other value that's being used to calculate an AUC. If you're coming from an institution, either large or small, there's going to be a lot of moving parts in this transition. So your Bayesian dosing champion or expert may not be able to address all questions or all clinical areas of your department at once. So this is really where a super user process might come into play. I think those of you on the call that are in leadership roles probably know who your high-performing staff are. So definitely seek them out and use them to your advantage. Choose providers from different areas or shifts so that there's more likely to be at least a few super users working at any one time. Those super users should receive more intensive training to answer more nuanced questions. And we should really encourage those super users to be the frontline experts. Then that Bayesian dosing champion or coordinator can focus on more complicated questions or issues as they arise. And also consider scheduling huddles with these super users, maybe on a biweekly or daily or however often basis. And those implementation coordinators would join that meeting to ensure that all of the issues are addressed in real time. I think importantly, we don't want to forget these super users when it comes time to yearly performance reviews as well. So we realize there are a lot of moving parts here. How do we keep it all together? This is really where our implementation checklist or our roadmap for our transition comes into play. We want to try and break down larger tasks into smaller goals and clearly define roles and responsibilities for all those involved. We want to ensure that our deadlines are appropriate and realistic and are set so that they have ample time to consider all of the steps that need to occur so that you can meet your go live date at the designated time. In addition to mapping out what needs to be done, the implementation checklist is also a means of holding participants accountable to ensure that there's no inadvertent or extended delays in this process. And for us, the process of transitioning over to Bayesian dosing platform really unfolded over several months from initial concept to final implementation. So we had to think about, as we get closer to our implementation date, reminding our various key stakeholders that the transition was going to occur on a certain date and represent against some of those groups that are more likely to prescribe vancomycin, just so that they were aware that the transition was occurring. All right, so post-implementation, we spent weeks to months getting everything set up, and our Bayesian dosing platform is live. We're ready to dose patients with our Bayesian dosing software. What do we need to do? I think, again, even with all of the best training available, there's still going to be questions that come up in clinical practice that haven't been accounted for, or maybe there's a slight variation of some case that was presented previously. So really these daily vancomycin rounds that we did for the first several weeks was a great opportunity for those that were on the front lines doing the dosing to interact with our designated Bayesian coordinators and really ask the experts, so to speak, in real time. And that was a really nice discussion for us. One pharmacist may have had a question, but it was really a group discussion in our various satellites, and I think it was quite productive. We want to encourage our staff to submit challenging or interesting cases for review, because ultimately you're going to revise your vancomycin dosing protocol, but realistically, as it's rolled out into clinical practice, you may realize that you need some changes to that protocol based on various cases that do occur. Really, for us, this also provided a unique opportunity for some recorded how-to videos, which we hosted on our intranet site for staff to watch at their convenience for commonly encountered dosing situations. We also noticed that there were a handful of questions that we received several times, so we incorporated these into our living FAQ document for our staff to reference. On both accounts, we received positive feedback. So as an antimicrobial stewardship pharmacist, I can't help but include a plug for metrics. You want to measure your success, and likely your key stakeholders are going to want to see some data. Some potential metrics are listed on the slide, but what you choose will ultimately depend on what baseline data exists at your institution, or what data can be pulled from electronic or automated reports. Seeing you're going to be measuring this data anyway, don't forget it as one of your antimicrobial stewardship metrics for your next accreditation visit. And with that, I have two final comments. One, there's no one-size-fits-all approach here. You have to do what's best for your institution. And two, the clinical why here should be fairly easily justified based on what Tom and I have presented. The how-to is arguably the biggest challenge. So implementing a Bayesian platform or other AUC-based dosing strategy is primarily an exercise in change management. In order for the transition to be successful, and an appropriate change management strategy is key. So now I'd like to turn it back over to Christy to discuss some of key resources in helping you manage this change.